Hey everyone, how's it going? My name is Brandon Fierstead.
I'm Hannah Schultz.
And I'm Shannon Smith.
Today we will be going over our HS 510 Group Process Improvement Project, where we'll be discussing and talking about some of the interventions for reducing 30-day readmission rates. For the agenda for you to follow along with us today as we go through the presentation, we will start with the introduction and background. We'll state the problem, purpose of the project, significance of the project, leading into the literature review, methodology, conclusion, and finalizing with our references.
Our research was on reducing 30-day readmission rates, which is defined as a patient being admitted to a hospital within a specified time period after being discharged from earlier and mainly initial hospitalization. For Medicare, this time period is defined as 30 days and includes hospital readmissions to any hospital, not just the hospital the patient was originally hospitalized in. In 2010, Centers for Medicare and Medicaid Services reported almost 20% of Medicare patients, or approximately 2.6 million older adults, were readmitted to a hospital within 30 days of discharge. When these return visits are not prevented, they can be very expensive, and estimated costs exceeding $2.6 billion every year, or more than $1,000 per readmission. In response to this, Medicare implemented the Hospital Readmission Reduction Program, or HRRP. Hospitals with readmission rates exceeding the national average are penalized by a reduction in payments across all Medicare admissions. So, the overall problem is discharging patients from the hospital is a complex and costly process. When adding the complexity of required transitional care for individuals aged 65 and over, the process of discharging a patient can become even more challenging.
Because it's challenging, this study is designed to determine the most effective transitional care model for lessening 30-day readmission rates for individuals aged 65 and older. This is prompted by the Hospital Readmissions Reduction Program and reimbursements. The significance of this study is to improve quality of care for patients and reduce financial stress and likelihood of CMS penalties for hospitals by determining what we believe is the most valuable transitional care model.
To be able to determine the most effective transitional care model, a review of a March 2009 Institute of Healthcare Improvement publication was performed. This publication was titled Effective Intervention to Reduce Rehospitalizations, which was a compendium of 15 promising interventions. Of those 15 promising interventions, 7 were focusing on the population or group in which we were trying to look into, which was Medicare or individuals ages 65 and older. Based on the data available for each of these models, they had been divided into 3 categories: very strong trial or evaluation evidence of effectiveness, very good evidence of reduction in rehospitalization rates, and promising interventions that require further data. As we make our way into the first category for interventions with very strong trial or evaluation data, we look at the first one being the transitional care model. The transitional care model is used to address the unmet needs of hospitalized elders and to improve outcomes after discharge. To meet the needs of these elders, this model operates under a set of 7 core concepts, which is led and focuses on the role of the advanced practice nurses. This model resulted in a less likely rehospitalization and less cost per patient of approximately $5,000. For the second model in this category, we focus on the care transition model. The care transition model is a 4-week intervention that again focuses on improving the care transition, but by fostering improved self-management skills. This again is done through an advanced practice nurse and also resulted in less likelihood of rehospitalization. Unlike the transitional care model that resulted in a cost of $5,000 less per patient, the care transition model resulted in a $500 cost less per patient.
The final intervention with very strong trial or evaluation data is the Evercare Care Model. Evercare serves individuals nationwide who reside in a long-term care facility or are living with chronic conditions in the community. The Evercare model embodies three main components. There are 4 levels of care intensity patients can be triaged into. In this care model, case managers or nurse practitioners provide care based on triage level. Results from Evercare care model implementation showed reduction in hospitalizations with an approximate $103,000 annual savings in hospital costs per nurse practitioner. Next, we will move into our intervention with strong evidence of reduction in hospitalization rates. Novant Physician Group Practice Demonstration Project. In this project, participants were provided with performance-based payments for improvements in quality and cost efficiency of healthcare delivered to Medicare fee-for-service beneficiaries. The chronic care model, comprehensive organized medicine provided across seamless system, or COMPASS, was implemented. There were 3 intervention elements for the provider and for the patient, each focusing on education and disease management. Results demonstrated that COMPASS implementation reduced costs per beneficiary and improved quality metrics.
Finally, we have 3 interventions that are promising interventions that require additional data to determine their effectiveness. The first is Project Boost. Project Boost stands for Better Outcomes for Older Adults Through Safe Transitions. This was created to enhance the transition of care from the hospital into the home. Not only is the objective of Project Boost to reduce 30-day readmission rates, but also to improve patient satisfaction scores and improve the flow between the hospital and the outpatient. To do this, Project Boost uses a toolkit that is built into the electronic health record that allows the same information in the office be given to the patient when it was also as they're discharged in the hospital. Next is Guided Care. Guided Care is a program utilized for patients needing assistance with managing multiple chronic health conditions. There are 3 core elements of this intervention, and they revolve around a placement of specially trained nurses within the primary care offices and an action plan being built for each patient. Finally, there's Hospital at Home. The core components of this intervention are daily physician visits and the care and patient education coordinated by a registered nurse. Only patients who are sick enough to be hospitalized but stable enough to be treated at home would be eligible for Hospital at Home. It is important to identify the appropriate patients, extended home visits with a physician, as well as implementing a rapid response system for physicians and nurses if symptoms worsen.
So this information came from secondary research that was collected through Google Scholar and PubMed Central Bases. Search words included all of the models' names, as well as terms such as geriatric readmission rates and interventions to reduce readmission rates. Results only included scholarly journal articles and textbook dated 2006 and newer. Of those 7 interventions, reviewers selected the transitional care model as a best practice with widened applicability to increase quality of care and decrease readmission rates.
Lean Six Sigma methods can be used to reduce 30-day readmissions among those aged 65 and older. This approach allows for better planning from admission to post-discharge and results in increased quality of care and lower hospital costs for preventable readmissions. Adoption of the transitional care model through Lean Six Sigma strategies will provide increased quality of care, decreased cost, and help with hospital accountability for CMS performance measures related to 30-day readmissions.